Uh, Good morning. I want to welcome you all to our first ethics grand rounds of the new calendar year. I'm Ben Wilfon. I'm the director of the Truman Katz Center for Pediatric Bioethics. For those of you who haven't been to one of these grand rounds before, I want to spend a few moments explaining to you kind of what we do, because it's a little different from some of the other typical grand rounds. It's really a case-based consideration of issues, and we have a particular format in which we have a case that's presented by a children's clinician. In this case, we're going to be actually having two clinicians share the presentation of the case. The cases are typically inspired by real cases, but somewhat become elaborated and expanded for general teaching purposes. So you might recognize some familiarities, but also, in fact, you might notice some differences from things you might have experienced because we're changing this for purposes of education. After the two presenters cumulatively talk for about 15 minutes or so presenting the case and raising some issues, we'll have our invited commentator speak for about another 15 or 20 minutes or so, and then hopefully we'll have a good 20 minutes left for conversation moderated by our commentators. So there are two microphones at either aisle, and the reason for that is so that our speaker knows who wants to come up next to talk. So I'd encourage you to make your way to the microphones if you have questions, and often that question and answer period is the most engaging part of the session. We also, again, we want to stimulate discussion, and we also anticipate people will have different points of view, and we encourage everyone to be respectful of those different points of view. This is a quarterly activity. It's supported by a fund that was originally set up by Jeff Sconyers and Deborah Godfrey, and we're very appreciative of their support of our program. I want to make two more quick announcements of future activities before I begin introducing our speakers for today. Our 7th annual Summer Pediatric Bioethics Conference will be held on July 22nd and 23rd. The title of that conference is Who's Responsible for the Children? Exploring the Boundaries of Clinical Ethics and Public Policy. And this should be a very exciting conference, and we encourage you to, actually yesterday we sent out the first save the date announcement on the email, so you can go there and see the information on our website currently. Our next case-based grand rounds will be on May 13th. The clinical presenter will be Brian King from psychiatry, and our discussant will be Dave Wendler, who's a philosopher at the NIH. The topic of the next grand rounds will be on research on children with intellectual disabilities, waiving consent for research without direct benefit to the child. And so this should be a little bit of an interesting grand rounds related more to a research ethics issue than a clinical issue, but very relevant. So let me go ahead and quickly introduce our two case presenters. The case will first be presented by Dr. Sid Gospe, who is the chief of the Division of Neurology. Dr. Gospe has been here for about 10 years, most recently at UC Davis before coming here. He will begin the case presentation, then halfway through, he'll turn this over to Maggie Hood, who is with the Medically Complex Care Service. Maggie's been here for a number of years now. Prior to that, had been at Mary Bridge, and I really appreciate both of their help in organizing this with me. And it's really my pleasure to be able to invite to Seattle our commentator, Walter Robinson. Walter Robinson is Walter and I have many things in common, but one of the things we have in common is that both of us are pediatric pulmonologists from our original training. Walter went to medical school at Emory, did his residencies split between Boston and Johns Hopkins, and then did his fellowship at Harvard, both in peds pulmonary as well as in medical ethics, and was on the faculty for quite a number of years at Harvard, and most recently is currently at Vanderbilt with the peds pulmonary program there, as well as with their Center for Bioethics. And last thing I'll announce before I turn this over to Sid is Walter will be doing two other things today. There will be a seminar at 3:30 in Building 1 I forgot to mention that Walter is also, besides being interested in bioethics, also is interested in the history of medicine. In fact, is currently working in a book called The Kiss of Death about cystic fibrosis.
Oh, the kiss of salt.
Oh, The Kiss of Salt.
Well, that's book number 2. Yes, appearing nightly. Try the deal, tip your waitress.
Okay, on that note, let me turn it over to Sid. Well, wait. Walter will, afternoon, as a historian, he'll be at 3:30 at Building 1, he'll be talking about Willowbrook and giving us a very interesting historical account of what's known as the Willowbrook study that happened in Staten Island back in the 50s, and he has a very unique perspective on that. Sid.
Ben, thanks very much for the introduction and for inviting me to present today. I'm going to be presenting this case that several of us on the neurology service were involved in about a year and a half ago, and going to be discussing her presentation, her course in the infant intensive care unit, and then we'll be making a few comments about severe neurologic injuries in children and the concept of brain death in children. So this little baby's going to be going by the name of Claire, and she actually presented to Children's initially at 22 days of age. She had been a full-term newborn, and she presented with an episode of tachypnea. She was transported here from a community emergency department and was discharged a few days later with a diagnosis of gastroesophageal reflux disease and without any neurologic problems or any serious concerns. Unfortunately, 7 days later is when her second hospitalization occurred, and a very unfortunate situation developed when the baby had been taking a nap, and so had mother and an older sibling. And when everyone awoke, mother discovered that the baby actually had been trapped in a sling underneath her older sibling and had suffocated. Claire was unresponsive, pulseless, apneic, and cyanotic. Paramedics were called to the scene, and a very prolonged resuscitation ensued, which included chest compressions, intubation, and several rounds of epinephrine, after which her heart rate was recovered. She made her way down to Children's and was admitted to the infant intensive care unit, and her initial blood gas values were really quite concerning, with a pH of 6.65 and a bicarbonate of 5.6, which really was consistent with very severe asphyxia. When the neurology service was called to see her shortly after her arrival, she was noted to have a number of abnormal movements. So these were described as asynchronous myoclonic movements of the limbs, which most importantly were suppressible whenever her torso and extremities were repositioned. And while these looked like seizures, the fact that they could be easily suppressed or actually stimulated again by moving the baby around, this would be more consistent with spinal reflexes rather than epileptic events. Other than those movements, there were no other motor responses that she had during observation or during the examination. Noxious stimuli did not result in any withdrawal or postural changes. She had very brisk tendon reflexes, and as far as her brainstem exam, she had absent pupillary responses, absent eye movements, absent corneals, absent gag reflex. So all of her brainstem reflexes were not present. So this picture of neurologic picture was consistent with a lack of function of the brain and brain stem, and given her history and given these findings, her overall clinical picture would be concerning for a diagnosis of brain death. I hesitate to use the term diagnostic of brain death at this early stage of her presentation, but it's certainly concerning for that. And the neurology service at the time decided to obtain a STAT electroencephalogram, and that showed that there was no evidence of electrical cerebral activity did demonstrate some ventilator artifact, but no other waveforms. It's important to understand that this particular EEG was not conducted with the what are called the minimal technical standards for the determination of brain death. And what I mean by that is that if an EEG is being done to confirm brain death, it has to be done in a certain fashion where the EEG is run for a particular period of time. The electrodes need to be placed in a certain distribution over the cranium, and certain montages have to be used over the course of the EEG. And those particular technical standards are different from a routine EEG that we would do, and so they were not enforced for this EEG. The parents were told that the baby appeared to be brain dead, and a recommendation for withdrawal of support was made at that time. The parents were obviously devastated by this entire situation, and they expressed a great deal of hope that their baby would recover from this severe encephalopathy and would survive. Just briefly, this is an image of the EEG that was done on that day, and what we can see here is that in all of the channels there is really no evidence of electrical activity coming from the brain. The gain on the channels is turned up substantially, and so we're not seeing any signals coming from the brain. We can see some EKG artifact down here. This is an EKG channel in red down here, and we can see that these little spikes here are actually correlating with the EKG. So these are not brain waves, they're just heart waves that are being transmitted to the brain. And this other noise in here is actually coming from her ventilator. An MRI was done a couple days later, and she had a very abnormal MRI with severe restricted diffusion in the cortex and white matter tracts through the basal ganglia, the brainstem, and the cerebellum, all of this consistent with a very diffuse infarction of the brain. So over the course of the next 5 days, the baby did not have any improvement in her neurologic function. Her exam was unchanged with lack of function of the brain and brainstem. There were no spontaneous movements, no brainstem reflexes, no responses to noxious stimuli. And an apnea test was then performed, which is part of a standard brain death determination, and that did not show any spontaneous respirations when her ventilator was turned off and her PCO2 was allowed to rise. Another EEG was done on the 5th hospital day, and this is when the story gets more complicated in that her EEG has now actually improved. So she now has what's called a discontinuous background with burst suppression-like pattern and areas of attenuation following these bursts of electrical activity, both focally and in other areas of the brain, that could last up to a number of seconds. And interspersed with these periods of bursts were a number of spikes and sharp waves throughout the brain. So all of this activity is actually coming from the brain. Her brain waves are no longer flat. We actually are seeing some electrical activity coming from the central nervous system. So while her clinical exam was still consistent with brain death, her second EEG was not confirmatory of brain death. And the term confirmatory is important to put in quotes here. So here's what her EEG looked like the second time. We now have the gain actually turned down somewhat compared to the previous study, and we can see that there are a number of bursts of electrical activity coming in various parts of the brain, as well as these large periods of attenuation in between the bursts. So this is still an extraordinarily abnormal EEG, but it's not consistent or confirmatory of brain death. So the parents were informed that their baby had a severe irreversible brain injury, and that if she should survive this devastating injury, she would very likely develop a persistent vegetative state. The parents were very skeptical of what we were telling them. They really did not voice any belief that their baby had a persistent problem. They really thought that she would recover, and they based this a lot on the fact that they felt that our initial pronouncement of brain death had been wrong, because they were basing this on the improvement of the EEG. Their feelings were that they wanted to give their baby more time. They wanted her to be supported aggressively, and that they would reconsider their decision in 1 year as to whether to withdraw support. I'd like to spend just a couple of minutes talking about the concept of brain death, and then I'm going to turn the discussion over to Dr. Hood. Brain death is a clinical diagnosis which neurologist or intensive care physician needs to do a very comprehensive neurologic history and physical examination and be able to document that there is an irreversible loss of activity of both the brain and the brain stem. These are the important criteria for this situation. The concept of brain death really began probably a good 40 years ago or so, and when the original diagnostic criteria for brain death were discussed and published, pediatric brain death criteria were really left off out of the publication, with the caveat that pediatric brain is very malleable, that we don't understand a lot about injury in young brains, and we really don't want to have criteria out there. So it was not until 1987 that a task force was brought together to actually develop some pediatric brain death criteria, and those were published in 1987 with the following recommendations. That in order to determine brain death in a child, there needs to be 2 comprehensive examinations performed, separated by what's called an age-specific observation period. And for patients of this age, of Claire's age, the observation period has to be at least 48 hours. So in other words, there has to be one exam, then a 48-hour time period must elapse before a second exam is performed, which would also show loss of activity of the brain and brainstem before brain death could be diagnosed. Also, the criteria also required that 2 confirmatory tests needed to be performed at the beginning and the end of this period. And confirmatory tests were a number of different studies could be used, but most commonly it would be an EEG or a cerebral blood flow study. So in this particular instance, we can see that both clinical exams were consistent with brain death. The first EEG might have been consistent with brain death, but the minimal technical standards were not performed, so it was not a completely valid confirmatory test. And the second EEG did show some electrical cerebral activity, so was not confirmatory of brain death. Well, we can now fast forward to 2011, and a revised set of pediatric brain death criteria are about to be published. I expect that they're going to appear in print sometime in February or March in the journal Critical Care Medicine. The new criteria, instead of being a 2.5-page publication, is probably going to be somewhere on the order of 20 or 25 printed pages. And the bottom line is that for patients under 30 days of age, and Claire presented at 29 days of age, the observation period of 24 hours is going to be recommended, whereas for patients older than 30 days of age, a 12-hour observation period is all that is necessary. And most importantly, the ancillary tests, which is the term now as opposed to confirmatory tests, are no longer required except in certain circumstances. And those certain circumstances would be in situations where the neurologic exam can't be fully completed. For instance, if a patient has had severe trauma to the face or ears, and you could not do a complete brainstem reflex exam because the eyes are severely injured and you can't check for pupils or eye movements, that would be an example of when an ancillary test would be important because your neurologic exam would be less than complete. The authors have made it very clear that they want to avoid the term confirmatory test. They want the neurologic exam and the history to confirm brain death, and that these tests should just be considered ancillary to sort of help with the diagnosis if the clinicians really feel that the extra data would be helpful, or in certain circumstances if the family really needs to have additional clinical information to help them accept the diagnosis. I'm going to stop my comments right now and just see if there are any clarifying questions that people might have, and and I'm going to turn the conference over to Dr. Hood.